going to kind of hit a few different topics on this lecture. First one's going to be HIV and acquired immune deficiency syndrome. So, HIV and AIDS, first off, treatment of HIV and AIDS, it has progressed a lot, in the past 40 years, um, with antiretroviral therapy being the backbone of treatment for patients. So we are going to jump through, quickly skip over the epidemiology and the symptoms of HIV infections, and jump to the goals of treatment. So our goals of treatment are to achieve a maximal suppression of plasma viral load for as long as possible. We want to delay the development of medication resistance, which is very, very problematic, especially with patients who are non-compliant, where if the HIV virus sees an antiretroviral therapy with breaks in between, um, it will develop resistance to that antiretroviral therapy, and then it's no longer useful for the patient. We want to preserve CD4 T cell numbers. So as your viral load increases, your CD4 count drops. So you have a higher viral load. Excuse me. You have a higher viral load, and then a low CD4 count means you're more susceptible to opportunistic infections. And then you want to confer substantial clinical benefits, leading to reduction in morbidity and mortality. Um, with appropriate treatment with antiretroviral therapy, patients with HIV can have a long, healthy life. It's not the death sentence that it used to be. Back in the 80s when we were kind of figuring out what HIV was and where it came from. The rationale for treatment is antiretroviral therapy. There are more than 20 FDA-approved medications. It is a dynamic and rapidly changing arena. They're just the integrase inhibitors we'll talk about in a minute. That's a big change. They've kind of become the backbone of antiretroviral therapy in the past couple years. And it's always used in combination. You're never going to use a single antiretroviral therapy for treatment of a positive HIV infection. So, previous guidelines recommended antiretroviral therapy based on a CD4 count and an HIV viral load. But as of 2013, antiretrovirals are recommended regardless of lab values, given increased evidence of negative consequences of uncontrolled viral replication. So we don't wait for a CD4 count to be so low or an HIV viral load to be so high before we start antiretroviral treatment. We are going to start it immediately. And there's a lot better efficacy and tolerability with our newer antiretroviral therapies. Standard of care consists of at least 3 active antiretrovirals from 2 or more drug classes. It's very important. You have to have the different classes which work on different targets in the virus so that we decrease our chance of resistance developing. Resistance testing is indicated in treatment-naive patients and patients who fail treatment because resistance can be developed, and you can have a positive who is, even if they're just being diagnosed with HIV, they can have a resistant form of HIV towards certain antiretrovirals. Primary goal in therapy is an undetectable viral load. Therapy is going to be lifelong, and if patients develop drug toxicity, it is acceptable to substitute one agent for another one, but continue the other 2. So ongoing HIV replication leads to immune system damage and progression to AIDS. Treatment decisions should be individualized based on the risk of disease progression, indicated by HIV RNA levels and CD4 measurements. The most effective way to achieve sustained suppression is combination therapy with anti-HIV medications. So regardless of their numbers, you're going to treat, and then you're going to use their numbers to see if you have an effective treatment. Antiretroviral therapy should be initiated within 14 days of initial diagnosis. Some things to take in mind are pregnancy, hepatitis B co-infection, and HIV-associated nephropathy. Now, for our hepatitis B co-infection, HIV infection along with it does not preclude them from still being a candidate for one of our hepatitis. I'm sorry, that's hepatitis C. It does not preclude them from any type of treatment for any type of hepatitis they may have. Antiretroviral treatment, or ART, I'm just going to shorten it for ease in this lecture, is determined by comorbid conditions, convenience. That's a big one there, because we're now getting anti-ART that comes multiple medications in one tablet. So if I can take one tablet once or twice a day, then it's a lot easier than taking 3 tablets 3 or 4 times a day. Genotypic drug resistance and HLA-B 5701 testing if we consider using abacavir. So initial antiretroviral regimens, how do we choose? Here's a list of commonly used components and what their advantages are. So you'll see a lot of advantages in that. The first couple are that they're co-formulated together, so you can take less tablets. Each one does have a disadvantage of potential adverse reactions. Then you get into the integrase inhibitors at the bottom, the ones that end in egravir. They have limited drug interactions, and they have a lot better tolerance, and food usually doesn't affect their absorption. So those are going to be usually ones that you're going to use are those integrase inhibitors as one of the 3. So the recommended treatments as of June 2016 are 2 NRTIs plus another medication. So we're going to use 2 NRTIs plus a protease inhibitor, or 2 NRTIs plus 1 integrase inhibitor. And you can see some of the options to begin with below. So there's 6 families of HIV retroviral therapies. These are those 6 categories. Here are the ones listed. You'll see that each one has a 3-letter abbreviation. That's common with HIV medication, so that they can say the patient is on, I'm just going to make one up, this is not an actual combination, but they're on abacavir, M-tricytidine, and darovaserine. So ABC, FTC, DOR. Then you would know kind of because the names can get so complicated. They have protease inhibitors. You'll see here that a lot of them are also given in combination to increase the serum levels. We have a fusion inhibitor, integrase inhibitors, CCR5 antagonists. There's just one of those, and a post-attachment inhibitor at the bottom. That's one of our newest antiretroviral agents. We also have a lot of fixed combinations. So these come in either 2 or 3 drugs combined. You'll see some with even 4 drugs. That extra drug is usually to help increase the efficacy of one of those drugs. It doesn't actually fight HIV, the virus. And so you can see there's lots of different combinations, and there's even more than what this list had. One you see a lot is Truvada, which is actually a 2-drug regimen, which is one of the drugs that's also used and FDA approved for prevention of HIV infections for patients who are at risk due to like lifestyle choices, or who you know what I'm saying. You see the commercials for it. They're very effective, excellent choices for patients who maybe have IV drug use, males who have sex with males. Those few populations that the prevention of HIV is indicated for, these are very, very effective. Highly recommended that they start these. They're really very tolerable, and I think a lot of patients, once they get on it, once you can kind of get over the stigma of maybe being on one of these medications, that most patients don't. Most of them are not going to realize they're taking it. They're not going to have a long-acting side effect, a long-existing side effect from it, and it's going to really help dramatically lower their risk of an HIV infection. So highly recommend it for those patients. You're also going to see these drugs used for if you have post-exposure prophylaxis. So someone that comes into contact with blood from a patient who could potentially be HIV positive, needle sticks, accidental in the workforce or in outside of the workplace. You're going to give this 3-drug regimen for adults and adolescents to prevent a potential HIV infection. So the risk of infection post-exposure is very low, but we still want to make sure that we want to make it 0. So with post-exposure prophylaxis, our risk of infection drops significantly more to almost 0. Occupational exposures you want to confirm the exposure that the needle stick did happen, whatever it may be. And if I'm leaving stuff out, forgive me. I don't do HIV infections. At our hospital, we've had several patients who are HIV positive. We actually refer them out to specialists and we follow the recommendation to a T. Whatever they recommend, that's what we put them on. We bring them back for all the testing and everything because I understand how strict and how compliant they have to be. So we default to the specialist. So there's a chance I'm forgetting something in one of these steps. But you want to provide treatment immediately after confirming the exposure. You're going to give tenofovir DF plus emtricitabine plus raltegravir for 30 days. And you want to do baseline and follow-up tests and counsel on safe sex practices for the person who got stuck or a person who had the exposure, just in case they do come back positive. The risk will be almost 0, but you definitely want to make sure that you practice, you counsel them on that, because there's a chance that you don't want them to be contagious before they find out when they do their follow-up testing. So pre-exposure prophylaxis for persons at high risk of HIV. I think these are becoming a lot more affordable. I think insurance companies are covering them more. I believe PrEP is after my time in the outpatient world, so I don't know for sure, but I believe it's becoming, more covered by insurance, which is fantastic, because we're going to give Truvada, 2 HIV medications in a fixed combination, very easy to take, and you can take it once a day for pre-exposure prophylaxis. So you may want to consider it for any of the following populations deemed at substantial risk. So based on the number of new partners, the frequency of condom use, as new STDs, sexual practices, sharing needles, for males for sexually active adults, males who have sex with males, heterosexually active adult men and women, adult injection drug users, and adults with HIV seropositive sexual partners. So that's one where one adult is HIV positive and the other one is not, to help prevent prevent transmission of the HIV virus. So obviously you would use other means of protection also, but this PrEP would help dramatically decrease the risk. You want to confirm HIV status before PrEP is initiated. That's very important, because if for some reason they are HIV positive, now we're giving them 2 medications, not the 3 from 2 different categories they need for actual treatment of HIV infection. So we're running the risk of causing resistance. You want to screen for other sexually transmitted diseases, hepatitis B, sufficient renal function. You're going to give tenofovir and emtricitabine, or Truvada, comes together as 1 tablet once a day. It says for 90 days, but you can continue it long after that. And you want to screen for incidents of HIV infection every 3 months. You're going to monitor renal function, screen for STDs every 6 months, and then you're going to do ongoing risk reduction and counseling on condoms and safe sexual practices. Cost considerations, they're expensive. There's lots of programs out there, thankfully, that can increase access to this. The Ryan White clinics are great. Free clinics may have some uh, eligible patients, and then there's lots of copay cards if they have insurance, but it will not cover it. That can really help out. Resistance is our biggest issue with medication. That's why we want to push compliance, and we have to test the resistance of the virus in between medication changes. ART failure is defined as failure to maintain or achieve suppression of the viral load less than 50 copies per milliliter. It can either be failure or it can be virological rebound, and causes could be suboptimal adherence or toxicity. So, discontinuation or interruption in antiretroviral therapy is associated with HIV viral rebound, immunity compensation, and clinical progression of the disease. It may become necessary for short periods, but we want to start it back as soon as possible and prevent any type of interruption that can be prevented. Monitoring is fairly straightforward, and you're going to want to evaluate based on each individual patient and how they're doing. Final points: compliance is very important. Always check for drug interactions with your antiretroviral therapy. It's very, very important. If you have somebody who is on antiretroviral therapy, even if you're not managing their HIV infection and their medications, check a drug interaction every time you start a new medication. Every single time. Because they are very hepatically metabolized, very heavy in the cytochrome P450 family. A lot of stuff can affect their serum level. Always, always, always check drug interactions. If you can, allow someone specialized to manage their antiretroviral therapy. And patients with HIV do require more vaccinations than the normal population, or patients without HIV infections. So refer to the CDC guidelines for those. Quickly, primary opportunistic infections. These are infections you are going to automatically prescribe medication for to prevent the infection. Pneumocystitis, you're going to give medication if the CD4 count drops below 200. You're going to give Bactrim one a day, Bactrim double strength one a day, or single strength one a day, or double strength 3 times a week, and you have your alternatives there. Toxoplasmosis, you're going to give treat if it drops below 100, and Mycobacterium avium complex if it drops below 50, and that's azithromycin, 1,200 milligrams a week. Now, that is because those infections are much more likely in these patients once their CD4 count drops below it, because the body's not able to fight those infections. So you're going to automatically do it if their CD4 count drops below that number. Here's some more resources for treating HIV patients, and then we're going to jump into quickly doing different populations with their kinetics. So, from a historical perspective, basically just remember, now we finally understand that pediatric patients are not small adults. They metabolize and absorb medications different from adults. We're going to jump through the history, and it talks about the requirements of studies and how you have to look at pediatric patients separately, which is why right now we have COVID vaccine for adults but not for children, because you cannot extrapolate results from adults down to children. And so, keep going. So, how is it, some of the differences? So, GI absorption, gastric pH does not reach adult values until 20 to 30 months. So, oral bioavailability of acid labile compounds is increased, like your beta-lactams. So you're going to want to dose based on body weight, not just based on the number of milligrams for a certain infection. You can see that pH values change, which can affect how drugs are absorbed. They also have abnormal or developing GI tracts, so they're not going to absorb as well in the small intestines. Distribution, they have higher percentage of water, and their blood-brain barrier is incomplete, so it's a lot more permeable when they're newborns. And Infants younger than 6 months of age have decreased plasma proteins available for drug binding. So if you have to give somebody like phenytoin, which is bound to albumin, they're going to have less protein, so a smaller phenytoin dose will equal a larger serum level. Total fat decreases in adolescence as they become closer, more in line with adults. Where the differentiating age is depends on the person's body. There's plenty of 15-year-olds who have the body, of adults. They're, guys are, 6 feet something and large, and there's some that are not. So you know what I'm saying. You need to take into account the developmental stage of a person once they're in adolescence. They're not all. There's no set defining age that says, okay, 16 or 18, you're an adult. Here, take an adult dose of medication. Take each patient into consideration. Enzyme maturation also is at varying rates, so you're going to want to account for drug interactions. So these are the separate ones. You can read through how each one varies. Excretion, renal blood flow, and glomerular filtration reach adult levels at 9 months. So you adjust doses of medications to account for decreased renal function, but lower than that, and avoid ibuprofen before 6 months of age. Excretion of drugs in breast milk, obviously very important. Look it up if you're for each drug if you have a patient who is breastfeeding. Transgendered clients as patients. This is a newer chapter. Obviously, this is more prevalent now than it was 10, 15, 20 years ago. So I personally don't have a lot of experience in treating patients like this. We've had 3 or 4 transgender patients, but we've never had somebody who was actively transitioning in our care. So we've had to do hormone replacement, but never the transition part of it. So I again would leave that to someone who specializes in this, and then just follow the recommendations that are made. There's definitely areas of medicine that I just leave up to who's doing it. Oncology, HIV infections, transitioning, transgender patients. I leave it up to the specialist. You just tell me what to do, and we'll monitor as necessary. So the big part of it is going to be the hormone. The hormones that you're going to give. So you're going to give estrogen therapy to adults who are transitioning to female. You're going to give along with an anti-androgen, so you're giving androgen plus blocking testosterone to have the permanent effects of breast development, decrease in testicular volume, and sperm production. So they are permanent once you start giving these hormones to the patient. You do have reversible effects, which you can see here. And then some things that are going to be unchanged is the vocal pitch, the Adam's apple, and any already established facial or body hair. The risk with giving estrogen for anybody, whether they're, no matter what gender they are, thromboembolic events, coronary artery disease, lipid panel changes, hyperprolactinemia, prolactinomas, and bone mineral density changes. And there have been reports of prostate cancer that come along with it. You're going to give spironolactone because it suppresses the effects of testosterone synthesis. It aids in breast development. It's also a side effect that you get from it, gynecomastia, in males. Slightly reduces male pattern hair growth and stops male pattern hair loss. An adverse drug reaction is hyperkalemia. And then you're also going to use alpha-5 reductase inhibitors for any male pattern baldness that may have already occurred. You're going to give gonadotropin-releasing hormone analogs, decrease the production effects of testosterone, and any alternative anti-androgens you may need. For patients transitioning from female to male, you're going to give testosterone therapy. just like what happens during adolescence when male patients are developing. You can have it inject. They're going to have endogenous testosterone, so we have to give exogenous testosterone. Give it to develop those traits. So you can have it injected, which is the way I've seen it done. It seems to, nobody likes needles, but to me that's where you get the most effective absorption and consistent absorption. You have gel, patches, oral tablets. You can have implanted pellets. You're going to have a deepening of the voice within the first 3 months, and menses you typically cease within 6 months. Therapy risk: persistent menstrual bleeding, erythrocytosis, androgenic alopecia, and migraines can be exacerbated because of this. And so you have some more medications for menstrual cessation, contraception. Let's see. Here's how you could treat patients in adolescence. Let's see. So if you are treating these patients, their sexual health and history should be assessed. Treatment should be based on anatomy present and patient behavior. HIV risk is high. Risk is high in trans feminine persons. Offer pre-exposure prophylaxis, and you want to assess the sexual function. And quickly, geriatric patients. Patients, just like pediatric patients, they have changing kinetics. We talked a little bit about this in the intensive lecture. They're a fast-growing population. They have a high tendency for polypharmacy, where medications just keep getting added and added without, we're getting medications to treat a side effect of another medication. They end up getting sedated. They can be confused. And they end up getting over-treated. And it hurts. What hurts them is that they're probably going to multiple providers and then possibly getting their prescriptions filled at multiple pharmacies. So nobody may have a full grasp on all the medications they're getting. Aging patients can have mental status changes. They have an increased susceptibility of delirium and cognitive side effects, especially with anticholinergic and medications that cause sedation. They can have sensory changes in sight and hearing. They can have a diminished smell and taste. They can have decreased peripheral sensations, and they can have musculoskeletal changes. Sorry about that. Oh, all right. Pharmacokinetic changes. Absorption is not dramatically different in older adults and younger adults if it's in the GI tract. As long as it's not a medication that needs an acidic environment for absorption, because pH does increase to become a more basic environment. Distribution: you have increased fat stores, decreased total body water, and lower serum albumin. Metabolism: you have decreased hepatic blood flow and decreased cytochrome P450 function. Excretion: you have decreased renal mass and lower serum creatinine, or you have lower kidney function. Serum creatinine is unreliable in elderly patients. Usually for an elderly patient, if their serum creatinine is below 1, you round up to 1. That is because creatinine comes from muscle. Elderly patients, for the most part, have a lower amount of muscle than younger patients. So if you don't have muscle to break down, you don't have creatinine to measure to check kidney function. So even though they have a normal serum creatinine, they don't have normal kidney function just based on their age. They're at a high risk for adverse drug reactions on a lot of medications. So you want to, before you prescribe anything, you want to collect a complete drug history and revisit it every 6 months. You want to avoid a drug if the benefit is only marginal, Evaluate their drug list for any duplications. That happens a lot. They have lots of duplications in medications, or they can a new prescription's written and they just keep filling the old ones along with the new ones because they're not sure what to stop and what to start. So it's great to give them a new med list every visit they come in. It's very helpful, and tell them what to start and what to stop. You want to review drug lists for any adverse drug reactions and ask the patient if they're experiencing anything, and prescribe non-pharmacological treatments if you can. Ensure the patient that a symptom is not a part of normal aging. If applicable, make risk predictions and then start low and go slow. Increase their doses slowly and start with as low a dose as possible. Make sure the patient maintains a medication list, brown bag to each visit, bring their medications in so you can go through them. Give them drug information sheets, use pill boxes, and reconcile medications with all care transitions, so any change in care. So inappropriate prescribing, there's some good references to look at. The Beers criteria, that's a list of medications to avoid in patients. Start-stop list or start-stop tools are good ones to look at also for medications that can cause mental status changes or have adverse effects on the elderly. And you want to avoid drugs that have narrow therapeutic ranges, have slow elimination risk, totally dependent on kidney excretion, high drug-drug interactions, or high adverse drug reaction profiles. So these last few slides, there's about 15 slides on immunizations. I'm going to let y'all read through those. It goes through flu, pneumococcal, when to give each one of the pneumococcal vaccines, zoster. Shingrix now is pretty much taken over the market over Zostavax. It's because it's more effective. It has a better, it's more effective. It lasts longer, and it just altogether a better immunization. It goes hepatitis B, and then a few other ones like Gardasil, meningococcal disease, and that kind of thing. So when to give each one. So I'm going to let y'all read through those. There's about 15 or 16 more slides. That's all for Module 14. If you have any questions, let me know.